Thanks for joining us again for Clinician's Brief, the podcast, the conversations behind the content. I'm your host, Dr. Alyssa Watson, and we've got a fascinating episode for you today about a unique dermatology case. Here to share her expertise is Dr. Ashley Detwiler, a dermatologist at Pittsburgh Veterinary Dermatology in Pennsylvania. Dr. Detwiler's article, Recurring Pruritic Skin Lesions in an English Bulldog, is an interactive case-based quiz intended to help clinicians generate a problem and differential list. We're also going to use today's discussion to learn a little bit more about the diagnosis and treatment of the autoimmune disease pemphigus foliaceus. Thank you so much for joining us, Dr. Detwiler. How are you doing tonight?
I'm doing well, thank you. I appreciate you having me.
Yeah. Before we jump into this case, could you just take a minute to introduce yourself to the audience? Tell us how you got where you are, what got you interested in dermatology?
Sure. I guess briefly, but in some detail. I'm originally from Florida, Fort Lauderdale, Florida. Now I live in Pittsburgh. So the route to get here, I grew up, born and raised in Florida and all through high school, South Florida, and then went to University of Florida for undergrad. Started the diversity of everything vet med to get into vet school. Horses, cows, working at the vet school, everything. And I worked as a surgery tech in the University of Florida Vet School, and then as an oncology tech. And that was my first real connection to specialty medicine. And I did see that early that it was different, and it just had a different connection that I really liked with clients, especially in oncology. And then went off to vet school at Mississippi State. That was 2006 to 2010. So I graduated in 2010 from Mississippi State Vet School. And I did know, I guess it was my third year transition, that in vet school that I wanted to do some externships in specialty medicine. And the dermatologist at Mississippi State University did have a unique role, and she would come in a few days a week. And so that offered some exposure. And then she also encouraged a lot of outside externships. So she got me connected with a great dermatology group in Auburn and then in Florida. So it just kind of went from there that I started connecting by way of a great mentor in vet school, and then went out to meet some of her mentors. And this interest in what I thought was oncology via specialty actually moved into dermatology. And I noticed during vet school and during those externships that I really loved the connection to the client and the cases. They were puzzles. They were very unique. They were chronic and ongoing, but they were ongoing. They didn't have some of the end result you see in oncology. And so I actually thrived in that experience. And then I was able to get an internship with Mississippi State the year to follow, and then was very, very lucky to immediately match in a dermatology residency at Michigan State. So I went from Florida to Mississippi, then to Michigan. Being a Floridian in Michigan was kind of fun. But I was there for 3 years. My husband is a veterinarian as well, so he did some training there when I finished. And then we went, after 3 years, we went to the MedVet Corporation had a clinic in Cincinnati that needed a dermatologist and a radiology resident. So my husband's a radiologist, and we were there for 4 years. And then after that, I am now on year 5 in Pittsburgh. So we moved from Ohio, Cincinnati to Pittsburgh, Pennsylvania. And I've been here and I've been very happy. And it's been a journey kind of around the country, but only east of the Mississippi River. But varying degrees of weather and seasons, and now what I thrive in, which is pollen. More so professionally, I thrive in pollen, not personally.
Well, I think it's wonderful that you kind of recognized in yourself that you love that connection with the clients and, having that ongoing relationship, because that is something that, like you said, dermatology cases oftentimes are you're going to be seeing these patients for their entire life. So,
Yes.
So let's talk a little bit about, like I said, you had written this, case-based kind of interactive quiz.
Mhm.
And it starts out introducing Hope, who is an intact English Bulldog. And I encourage everybody at home, we'll go ahead and link the article in the description, but go take a look at these pictures, because this poor sweet dog, when I looked at her, I thought, oh my goodness, she seems to have a lot going on. So could you tell us about her presentation, how she ended up coming to see you on, I believe, what was a second opinion?
Yeah, so we met her during our curbside COVID appointments, which meant if no one had experienced that, that we were not face to face with the owner, and we met patients really in a different manner, and many times when we walk into exam rooms that have patients that do look like Hope, it's like a reaction. You're definitely taken aback, by her presentation. It was very severe. She was diffusely affected. And in this situation, we didn't meet with the owner immediately. We spoke with her immediately. And so, and I guess in a good way, it was, we were able to evaluate her and just have a moment where we're like, wow, this is a very different case. And she was a different case even for the referring veterinarian. So when she came into her referring veterinarian that was close to our South practice that's in Washington, PA, she was coming in with the intent to potentially relinquish to euthanize because the owner, I don't remember the extent of what the owner's involvement was with the dog, but I think their goals or someone's goals in her history was to breed her, or maybe she had been bred. So the history right there at possible relinquishment with the original owner was a little sparse, but she ended up being relinquished and not being euthanized. And one of the employees at this referring practice actually took her took her and adopted her. And so now the case was really close to the veterinarian because it was at the clinic all the time, and they did a lot of work on Hope and recognized very quickly that she had very severe skin lesions. When she came in, she was intact. She was a young dog, presumed age of 15 months, but close, at least, approximately close, intact. And she was just had red, swollen, severely affected feet, more than I've seen in an average patient in dermatology, and just diffuse redness and various varying stages of lesions, and other things going on. Third eye prolapse. She had a heart murmur. She was painful. She was irritated. And so when she was seen at the RDVM, her primary vet did some workup, especially for resistant infection. And there was a biopsy completed before I met her. And I think because she had so much infection, especially resistant, methicillin resistant staph infections, when she was initially evaluated, I think a biopsy just didn't potentially didn't show the detail of what she was really dealing with. The other thing is we do have patients that come in with one presentation initially, and then they can present again with something different. And so as we learn about Hope in the entire presentation, in the entire article, she does have allergies, which is what her initial biopsy with her primary vet reported. But then when she came into us, which was, I think the duration of time under their care alone was a couple of weeks, if not maybe a month. It wasn't very long before they referred. And we were co-managing, a lot of her care because the owner did work at the primary veterinarian's office. So they did get her in pretty quick. And when we saw her, we were recognizing lesions that just didn't seem allergic in nature, just seemed more severe. And I should say also she had recurrence of issues like her bacterial pyodermas. And despite their efforts, she was very, very itchy. And she just wasn't responding to conventional allergy therapy or just kind of the average process that was used, for a severe allergy dog. Also, she was intact. So there was a possibility that she was flaring, in conjunction with, her heat cycle. Mm-hmm. So when we met her, there was a lot more going on that seemed to be present on top of things that were initially seen at her presentation to her vet.
Let's talk a little bit more about that biopsy, because I've heard that before, not just in Hope's case, but that, there are certain characteristics of pemphigus that can make it a difficult diagnosis, even on histopathology. And some of those things, like you alluded to, are secondary infections, right?
Yes. Yeah. And the interesting thing about the cell that we look for in the pemphigus diagnosis, which is the acantholytic keratinocyte, which is the prematurely lifted keratinocyte in the layers of the epidermis, it can be falsely diagnosed in a patient that has a really severe bacterial pyoderma, because there can be a breakdown of those cell layers of the epidermis because of a really bad infection, especially with the staph bacteria. And then you can also have an infection with dermatophytic species trichophyton, where you do see that same premature lifting of the skin cells, because those bonds of those skin cells are broken down by dealing with trichophyton and tegrophytes. So you're dealing with maybe bacteria that can kind of mimic the presentation of pemphigus, in that you see those acantholytic keratinocytes, which we'll talk about more with the biopsy detail. But then you can also have ringworm species. So bacteria and ringworm can mimic the finding, the cytologic finding, associated with pemphigus. But in the biopsy, especially, our problems really kind of boil down to how the biopsy is collected. And if you miss part of the tissue, which actually is that crust that sits right on top of the lesions, or an intact pustule, if we don't get those types of lesions, you can miss the biopsy, the histopathology diagnosis of pemphigus foliaceus.
So that is something that I have, again, over the years, I've heard different advice about where to take those biopsy samples. I've heard you should take them at the center of the lesion or at the periphery, because that's more active, or you should try to even incorporate some normal skin. Do you have opinions on where you should place your biopsies, and how many biopsies should you take in order to maximize your chance of getting a diagnosis?
Well, that's a great question, because especially with Hope being so diffusely affected, she had areas of her skin that could have been erythematous and irritated, and she definitely had a pyoderma when I met her. So we could have had allergy areas that were biopsied. And then, she could have had areas that were more specific for pemphigus. So when I look at a patient, I'm looking for primary lesions. I'm looking for secondary lesions. And my primary lesion for pemphigus especially would be a papule, but more so a pustule. So when I see a pustule, it's like a dermatology, a celebration. We're just so happy to see pustules. So if we're looking for that primary lesion and that pustule is present, I try to take care not to pop the pustule before I biopsy it. And really, I'm not trying to be sterile. I mean, derm biopsies really aren't sterile many times. We don't describe them as sterile, meaning there's not prep work to make sure that the skin is scrubbed and cleaned, because our sample's right on the surface. And then also, if a patient has hair, which some patients don't have very much hair when they come in with, skin disease, if the patient has hair, we're only clipping it short, because a surgical prep for the skin, especially of an animal, is to, clip that hair really short against the skin, and that can remove some of our lesion. So when I look at a patient that has a pustule, I'm taking a lot of care, and I'm not clipping the hair very short. I'm just maybe cutting it if the pustule is underneath the hair, if I can find one, around the hair, because they kind of hide sometimes. I'm also taking care not to clean it. Again, which sounds maybe confusing for the layperson,
A little
not
bit counterintuitive.
Yeah. And then also, I'm picking a punch biopsy that makes sense for the pustule. I want to keep that pustule intact. So I will say, on the average, I really don't use a 4mm punch. Most of the time, I will use an 8mm punch. And that's our biggest punch, short of doing excisional biopsies. But if I'm going to submit a sample from especially a large dog, and I have a lot of different lesions and they're big lesions, I want an 8mm biopsy punch. I want as much information from that patient as I possibly can get. Now, pustules can appear in weird places also, like not just haired skin, but on foot pads. So when we're dealing with foot pads and we have a pustule, it's a little bit harder because I also feel bad doing a punch on a foot pad that's going to have weight put right back on it when they go home because they're walking on all 4 feet most likely. And so I try to go for a pustule that's on a margin of a foot pad or maybe on the carpal pad instead of a primary weighted pad. But the pustule can be, punch biopsied off of a digital foot pad as well. And I try to stay maybe closer to the 6 millimeter punch just for the goal is to get my sample, but not to harm the patient. And I always do feel really bad doing the punches of the foot pads. So the pustule is as much as you can fit it into the punch biopsy and get as much sample as possible. The big thing with the pustule really also is, yes, the cells, underneath that layer that make the pustule are so important. But if you punch and the majority of your discharge doesn't ooze out, because there are some patients that have really big pustules. So if you can maybe catch the edge of a pustule versus going down in the middle of a pustule, if it's really big, I'm talking, there are patients I've seen, 2-3 centimeter pustules, and you're like, what do I do with this? But if you go on the edge of that one and try to just punch and then immediately get it into formalin, I think you retain as much as you can. But I do try to get smaller pustules. I do try to also share information with my pathologist. Hey, I did a cytology on a pustule. There's acantholytic cells. It is a sterile pustule, and so that guides them as well. A lot of information about pustules is more the merrier for sure. Otherwise, when I have a crust on a papule or a crusted pustule, I knew it was a pustule recently. A crusted nodule. I had a patient today. I feel like I'm going to get a pemphigus foliaceus diagnosis on, but the dog had more of like nodules and plaques, which was a little bit unusual. And so that patient, I was trying to get the oldest crust, with the older lesion, and then the newest, lesion with, a big heavy crust. And there's going to be variations of crust, but the crust can't be prepped and cleaned off and can't be trimmed off with the hair. So you're just cutting hair short versus trimming the hair like with a clipper blade. And we're not cleaning it. We're keeping the crust on top of the lesion. And I'm trying to get a really big biopsy punch there too, so I can get as much crust as possible. And there are patients that are going to have these 2-3 centimeter nodules and plaques. And maybe I'll go for a smaller one that's newer, to get all of the sample into the punch biopsy. I don't necessarily say to go to a center of a lesion if it's big. The center of an ulcer is going to be an ulcer. You might lose some of the information from it. So we try to get, cautiously stated, I try to get maybe the edge of a lesion, but I want to show the pathologist that I do have an ulcer. So I think the edges of ulcerative lesions are much better. But if that ulcer had a crust, I keep the crust on it. I try to find a lesion that had the crust. And many times I just go right down to the center. I get all of it in the punch if I can, or find one that I can fit into it. There's a lot of other lesions that can come with these patients, but many times it is the pustule or the crusted, patch or plaque or macule or papule. And then with, Hope's situation, she was extremely erythematous. She had foot pad issues. So we were just taking samples from everywhere. And I usually take at least 3. I think with her case, we ended up taking 6 biopsies.
Wow.
Including a foot pad. Her foot pads were, I think I have, there should be a photo of her foot pads in the article.
Yes, I think there was. Her poor feet looked so
Which was
painful.
an anatomic issue as well.
Yeah.
So she wasn't,
What about timing of taking these biopsies? Especially if you're seeing these patients after they've been seen by someone else, or after you yourself have put them on some medications. Like, should you have a washout period after steroids? Should you take them after they've been on a course of antibiotics? What is the best timing?
In some of our patients that we find a bacterial pyoderma on the first visit, and we're suspicious that these lesions need to be biopsied because we're dealing with something more than pyoderma or more than allergies, which I don't typically biopsy a patient when I have a strong suspicion they have allergy. So if we have a patient that like has a pyoderma, for example, and the lesion is just so essentially clouded by the pyoderma, I want to treat those many times, get them cleaned up, bathe even. We're going to do a lot of care to make sure that infection's cleaned up. And then we're rechecking them many times while they're being treated for infection, while they're on hopefully the right, type of antibiotic. And are using, the owners are using frequent topical therapy. And if those lesions are persisting and the patient is there that day on antibiotics and the topical, therapy is prescribed, and the lesion is not changed, and I don't have it on steroids, especially, as an example, I'll do a biopsy while they're on antibiotics and not necessarily need to get them off, because I know that when I first saw them, if I have this information that they had a pyoderma and I wanted to treat that first, now I have a cleaner sample for the pathologist, because pathologists are going to get, unfortunately, that bacteria, like I said, it just kind of clouds the process. It clouds the findings. And if you have a deep pyoderma causing these crater-like ulcers in some patients and, just really nasty dermatitis, and you clean that part up, but they still have an active disease that is just outside the norm, then our pathologist will be much happier reading the primary cause, getting that dermis or subcutis, with less furunculosis caused by the pyoderma. And they can really see, that primary inflammation or the target of the inflammation, especially. Those nasty pyodermas, especially deep pyodermas and furunculosis, many times you just don't get to see the quality of the dermis because it's all blown out in that case. And many times the epidermis is not present in, a nasty bacterial infection because of the pustules and the ulcers that are, formed. Otherwise, when we have patients, like I had a patient today that just came off of prednisone 3 days ago in prep for the appointment today, and we did a biopsy 3 days off of prednisone. And I would say we all kind of learn maybe they should be off prednisone for 2 weeks, to get the best sample. Well, that patient, and I do suspect he has pemphigus foliaceus, that patient had an active pustule, and I found a ton of acantholytic cells today, and that was 3 days off of prednisone. And so that was a great finding today for that patient. And hopefully the biopsy reflects that finding and we can help that patient. But there are some times where they come in on prednisone and their lesions are quiet. They are in different stages. They're more healed lesions than, and encrusted dry lesions than there are new primary lesions. So sometimes it just depends on the initial presentation. If we're missing something that we want to biopsy and we know could be there, we might have them come back, in a couple of days or a week. If they're really sick, and in pain, new lesions are happening regardless of being on prednisone, we're going to biopsy them right there, versus wait for it.
One of the other things about this case that was just a little surprising to me was with the diagnosis was the age of the patient. I guess I really didn't consider pemphigus to be common in such a young dog. Is there a median age of onset for pemphigus foliaceus? Are there any breed or sex predilections that I should be aware of?
So typically you wouldn't see it in a 15-month-old dog.
Well, I feel better then.
Right. Now, that said, I've had a couple of young dogs present. I can't say they were in the past month, and I can't say when they were in the past 5 years, or in since my residency even. But every now and then we'll get a young dog. And what we look for in the young dog is a trigger of inflammation, call it possible vaccine reaction. We always wonder, if something that was given at some point has triggered. So a drug reaction even. I don't want to just implicate vaccine, but if we dig hard enough, or there's an obvious something in the recent background, like an antibiotic, to implicate a drug, the young dog absolutely is important to consider an autoimmune disease. The young dog, like a year-old, or less than or very close to, like Hope was 15 months old, or presumably 15 months old. There was, like I said, a little bit of a splotchy history on her initial presentation to the vet. But having a young dog also maybe deal with like puppy strangles, or they're dealing with their own, hopefully, immune development and getting immunity from their mom. So depending on what has happened for that really young dog, if they unfortunately just have a bad go of it in their first 12 to 18 months, their immune system, may get out of whack, for lack of a better description, and we might deal with an autoimmune disease. But I think our biggest group of dogs dealing with pemphigus foliaceus, or the average presentation for autoimmune immune mediated skin disease, really is our middle age, dogs, or middle aged to older dogs. And there is kind of a discussion point that maybe allergy dogs are more prone to autoimmune disease, but I wouldn't say that hard fast. I would say we do have so many allergy dogs, and it's not uncommon that the dogs that get autoimmune disease probably have a history of allergy. So I don't want to say that every pemphigus foliaceus patient has allergies, or that allergies causes pemphigus foliaceus, but allergies are super common, and pemphigus foliaceus is the most common autoimmune skin disease that we deal with. And so on that note, we also see a lot of bulldogs with allergies. We see a lot of Labradors with allergies. We see a lot of different breeds, of course, represented, some more than others. And the more common presentation with pemphigus ends up being our Labradors, our bulldogs. I do feel like we see, and on the list of concern is also like our Cocker Spaniel, Dachshund. There's a few breeds that do stand out for pemphigus, or you see represented more often. But we have a lot of patients, and I wouldn't say, I think some stand out because they're sometimes a little bit more difficult to treat, or they have their own nuances. Like Hope was a very special case, and I do see pemphigus foliaceus represented in bulldogs more than I'd like to. They're just difficult cases. And bulldogs have their own anatomical issues with their folds, their feet, their skin folds, and when they get pemphigus, it's not pretty. Unfortunately, I feel like it's more diffuse in them.
There are some other diseases, though, that can cause, pustules, right, in young dogs. What are some other
Oh, yes.
differentials that you were thinking of when Hope came in?
Well, and Hope's presentation was not pretty from a standpoint of especially her age, so it was so severe, but it was so diffuse. And so autoimmune disease was on my list, but being the young age, it's, even though there were some differentials, already considered, allergies were already considered, and she had a biopsy that supported allergies. And we have young dogs that are very severely affected with allergies. But if she had allergies, there's definitely something more that was going on. So especially the pustule in the young dog, we have to immediately consider demodicosis. And I've had patients that maybe not as often anymore because of the isoxazolines that wonderfully treat Demodex. But I've had patients come in where they're just dripping pus off of pustules all over their body. And it's amazing how diffusely and severely affected a patient could be with demodicosis that's untreated. And that goes back to the immunity and, and the young patient. Why are they suffering so bad with that parasite? So that's very individual, and I feel like we have more success with those cases now. But if we don't find a Demodex patient in those pustules, we're looking at a pyoderma, of course. So we're looking for bacteria, and are they resistant bacteria, even in the young patient? I've had a couple patients present with puppy pyoderma, or even possible consideration for like juvenile cellulitis. That was maybe a mild case, and I'm getting resistant bacteria off these patients, and they're 12 weeks old, they're 5 months old, and it's amazing, unfortunately, how severe bacterial pyoderma can be, even in a very young animal, for whatever reason, and we have to sort through that reason and why it's a problem for that patient individually. And there is an odd, differential that we had on her list, or I should say, it got added to the quiz, and her presentation was just so severe. And I've unfortunately heard of, especially with my husband being a radiologist, that skin cancer, especially cutaneous lymphoma, can affect patients, or in general, neoplasias and cancers can affect patients younger than we want. And I have never seen a patient younger than a year or younger than 2 years with cutaneous lymphoma, but it doesn't mean it's not possible. And it's so important when we see a patient, no matter their age, that we do consider our differential list broadly, and then we let that history and the patient, hopefully, that presentation of young age and the diagnostics that we perform scale down that differential list. But if Hope was 3 years old, 5 years old, 10 years old, her lesions immediately would have been more considered. A higher differential would have been cutaneous lymphoma for her because of how severe and how many plaques, and just that the initial presentation was much different than expected for pemphigus. And so even though I shouldn't be seeing neoplasia that young of a dog, and it is an unusual differential to have for her because of the plaque lesions that she had, which were different, in general for her case. But I had to have some unique differentials on my list so I didn't get clouded, and didn't lose focus,
Right.
on what could be present. You just never know.
Are you on track to hit your CE goals? Clinician's Brief has more than 60 hours of practical, race-approved CE, perfect for catching you up and keeping you up on requirements. Whether you prefer to read, watch, or listen, Clinician's Brief CE is on demand and always affordable. Start earning CE today at cliniciansbrief.com/CE. So let's talk a little bit about, the pathophysiology of pemphigus foliaceus. We talked about acantholytic cells, they've always were described for me as that like fried egg appearance.
Mm-hmm.
That has to do with, right, how they're formed, right? How they
Mm-hmm.
lift up. And so,
Mm-hmm.
um, could you talk a little bit about that, about what happens with pemphigus to cause those acantholytic cells to form?
So the epidermis is made of layers, and when from the ground up, and so the base layer is our connection, that junction, basically that starts from the epidermis down to the dermis. So there's a base layer of the epidermis, and then all the skin cells are made in that base layer, and they work themselves up over time, kind of on average like 23 to 27 days. Don't quote me on that, but somewhere in the less than a month, you'll get a skin cell produced at the base layer that will come all the way up to the top and become a stratified, corneocyte, or basically that, dried keratinocyte that no longer has a nucleus. And so when it's first formed, it does have a nucleus, which is very prominent as it's growing or maturing. And there's different functions of each layer of the epidermis, but when pemphigus occurs, what happens is it's an autoimmune reaction. So the body is mounting a reaction to kind of averagely describe it as the brick and mortar is a visual description of the epidermis. So you have all these bricks, all these layers that are stacked, and the mortar is the glue that holds all those individual bricks together. And so pemphigus foliaceus is an autoimmune disease where those junctions, where that mortar is, attaching those bricks, it's basically breaking down that connection, to those bricks. So you're taking the base layer is still intact with pemphigus foliaceus, which is very important because there are some autoimmune diseases that will affect the base layer of the epidermis. But the cells that are trying to mature and go up to become stratified, epithelial cells, they kind of midway through the epidermis, you're getting that attack on those younger keratinocytes, and they are called acantholytic keratinocytes. They still have a nucleus, and they are basically those junctions, like I said, are broken down. So what happens is, as those cells are supposed to be connected with the mortar, they start to separate. Pustule then forms, so you have this bubble forming where you have neutrophils, eosinophils, usually not any bacteria, but you have this inflammatory infiltrate. And then these cells have now separated, from their connections. which is why the intact pustule and the crust is extremely important with the biopsy, because you need to get everything under the hood of the pustule or the crust, which includes that inflammatory population, but those skin cells as they prematurely lift. And the junctions and those connections that are broken down are desmogliin and desmocolin. Nobody needs to know that for everyday discussion with an owner. And that is board study information that you're going to put that aside too. I never say those words to owners, but those junctions, those connections between the keratinocytes, that's what's attacked.
Yeah, that's where all the action is.
Yeah, it's not the cell itself; it's the skin cell. It ends up being that literal mortar connection. Is separated.
And you had mentioned a couple of triggers, or precipitating factors for pemphigus. Definitely some medications are commonly, associated with pemphigus. I think there was a topical flea and tick medication several years ago that was yes.
And Certifact, I think, too.
Yeah, there were a couple of them there. But there's others, I think, as well. Like I believe sulfonamides. Do you have a list of antibiotics that you typically worry about?
My list is not like a daily worry, like I'm going to send these drugs home and I expect a reaction to occur, because that's super important, because I don't want people to feel like they can't use an antibiotic. For example, the patient I had today may be reactive to an antibiotic they had in the past, in that cephalosporin family. Mm-hmm. And that's what I'm working through with that patient. And in Hope's situation, we may never know the exact trigger. She was intact, and her estrus may have, triggered that, but she was also being treated for pyodermas, not with a cephalosporin. But my list usually includes a cephalosporin, or that group, the beta-lactams, if I'm considering an antibiotic as a possible cause of drug reaction, or a trigger for pemphigus. I feel like cephalexin is just so commonly used, so I don't know that it's like if we had always from the beginning used XYZ antibiotic, would we have seen that more? But the cephalosporins definitely are on the list more often, and then the sulfonamides, which I don't use very often, even in resistant cases. You kind of learn, over the years, like what you maybe shouldn't or shouldn't use, and you become patterned to that. You just either don't take a risk or just try to avoid it and do something else. With the skin, we can maybe try to avoid things and use more topicals. So truly with sulfonamides, I typically just try to avoid them, because I feel like I've heard of more reactions than I care to even try to combat. And so whether it's pemphigus foliaceus or other cutaneous adverse drug reactions, the cephalosporins, the beta-lactams, the sulfonamides are of more concern, for me. It is important, though, no matter the age of the patient, to consider recent medication use, recent vaccines, recent topical or systemic flea, and tick prevention. Anything that's ingested, anything that's put on the body, in the body. I've had a couple cases, I do feel like, with autoimmune disease, that something in their allergic history, is a part of their trigger. Like I said, I can't say that every pemphigus dog has allergies and it's always allergies, related. But I do think a lot of our pemphigus, if we dig through our histories deeper with pemphigus patients, we sometimes, or many times, can find an allergy. Are they causing each other? I can't say in every case. Or is the allergy causing pemphigus? Not necessarily. We do have patients that have neoplasia, or are dealing with other conditions outside of neoplasia, systemic illness, and they're getting triggered, systemic trigger, metabolic diseases, so we're looking for, in our older patients, is the trigger systemic? Do we need to do MET checks, lymph node aspirates and abdominal ultrasounds, chest x-rays, and those are discussions we have with every case. But as the patient gets older, why did this happen? Why is this, even though maybe they're middle-aged to older-aged dogs that are normal for pemphigus, or normally observed in pemphigus, are we missing something as an obvious trigger that maybe the owner didn't know about?
Kind of along those same lines, if you have an animal that you do diagnose with pemphigus and you're treating, what about future vaccinations? Do you hold off on those because they have a history of autoimmune disease?
I say on the average case that I treat, and maybe it's just a pattern I've developed. Um, I feel like the owners are leery during the process of treatment, especially trying to induce remission, because they're unsure about the disease itself. They're just really trying to get their pet under control. Our patients, we're just trying to get them in remission. So we're really cautious about everything and really wanting to limit the extras for the patient. And as soon as they feel better, I feel like that's when the vaccine question comes up, or they get a reminder card. Hey, I'm due for a vaccine. And sometimes the veterinarians will reach out to us. Many times we do get phone calls from the vets when they're at their annual visit or they need to do a recheck for pemphigus, for example, like in their vet's office, and we co-manage a lot of these patients. So when the vaccine question comes up, if I don't have as direct as I can make a link to a vaccine with any of our autoimmune dogs, if I don't have a direct connection or a major concern about a specific vaccine, I usually say, okay, let's change one thing at a time. If we're not making any major drug changes, let's say the dog is on prednisone and cyclosporin and doing really well, and I was going to maybe change the prednisone dose, and then this vaccine needed to be given. Let's say the dog needed to be boarded, or it was 5 years overdue for rabies, or whatever the situation is. They got a new puppy in the house. I would rather they, as and our whole team, the vet and the owner and us, feel comfortable with one change at a time. So go ahead and give a vaccine, and I would prefer one. Give one. Make sure that this patient, now in the state that it is, immunologically, make sure it can handle the one vaccine, which one is more important at that visit. And don't change the prednisone. Don't change the cyclosporin at that time. Keep the dog stable as much as we can. Give the vaccine, and then let's wait 2 weeks. I don't know, just kind of a broad recommendation. Give it a couple of weeks, see how the dog does. Because with any drug change I'm typically making, I'm giving the patient a couple of weeks to decide if it handles that change that I'm going to make. I just feel like I try to respect the immune system as much as I can. It's getting hit by all different angles, and we're just trying to calm down an autoimmune reaction. So I just prefer to be a little bit more cautious. When they're very, very stable and long-term managed patients, I think the owners get a really good idea of how they can judge that, and the veterinarians get more comfortable with it. But the newer diagnosed ones, I tend to wait until they're stable, and then make
That's
those changes.
No, that's really good insight. And it actually kind of leads nicely into talking about treatment. So, since that was the next thing on our list, you had mentioned prednisone and cyclosporin. So, are those really the most common immunosuppressive medications, or are there other things that you're reaching for very frequently when we have a case of pemphigus foliaceus?
Well, in my residency, because I was trained between 2011 and 2013, there were papers, there were book chapters that described treatments like gold salts, for example. And I personally have never seen or I've been around a patient administered gold salts. I don't have any experience with gold salts, but that was like then there was information and maybe some experience, still floating around. So I had no exposure to that. But when I started, also prednisone was still very common and still, and to this day, very common source of improvement for a lot of patients. But it can be used as anti-inflammatory to immune suppressive doses depending on the patient with a lot of success. But that was very much in my residency, part of the discussion. Prednisone, and here's some old stuff we used to do. But that secondary drug was discussed very quickly in all the patients that I diagnosed. You need to get your patient on prednisone to induce remission. And the discussion was then, what's your secondary drug? How do you then get them off prednisone? Or how do you co-manage them with prednisone so that you don't have the long-term side effects of prednisone? And in my residency, the discussion many times included azathioprine. Now, I don't use azathioprine as much now or as much anymore because I really try to use a lot of different medications so I can get used to all of them. And I think it just takes time to get used to different therapies. But in some patients, I try to give one medication, they don't agree, stomach wise. Another patient, they don't agree, maybe financially. If in azathioprine situation, when I've used azathioprine, my recommendations for rechecking blood work are much more intense than, for example, now I'm using cyclosporin and mycophenolate more, and the recommendations to recheck blood work are not as frequent based on how the drugs work. And so azathioprine has more risk, to the bone marrow and the liver, just in our patients than the short term, I should say, like in the first 4 weeks to 8 weeks, or the first 6 to 12 weeks. Azathioprine is a concern for bone marrow suppression and hepatotoxicity or liver enzyme changes. And so I'm very strict about azathioprine, and that goes along with getting blood work frequently. So some patients, can't come back for frequent rechecks, or the cost of the recheck and the blood work is difficult. And I can't say that the cost of other drugs is so much better and eliminates the cost of blood work. But in some situations, it's patients coming into your clinic, and it just ends up being a cost reality for clients. They've probably already been through some level of cost, prior to coming to us. Even in the biopsies are a cost. So the decision for the medication through my residency and now has always been, how do I get the patient under control as soon as possible with the least amount of side effects? And prednisone doesn't work for every patient in many ways, but it can work for a lot of patients, especially initially. So I always start with, or I tend to always start with prednisone or a close derivative, like dexamethasone or methylprednisolone. It just depends on the dog of how severe they are too, what my dose range ends up being. And then lately, I don't necessarily grab for azathioprine. I've been using cyclosporin, modified cyclosporin, I should say, brand name Etopica, but we do use generic modified cyclosporin, and we do use, I tend to use mycophenolate as well. And the side effects, I feel like, as long as we watch the dosing for the patient, tend to be tolerable. And our technicians are very comfortable with the medications as well. So it is also going back to educating the owner, the cost and availability of the medications, and how often the rechecks need to be based on the medications. Unfortunately, prednisone is the fast-acting medication, and all the secondary immune suppressive therapies tend to work after 4 weeks, maybe 8 weeks. So we do have to use that steroid, and then we do have to wait for the secondary medication to start helping, which can be a tough period of time.
Once you do get it under control, though, what's a reasonable approach to tapering these dogs off? Or are you letting people know right from the very beginning that these medications may be lifelong?
I typically describe the first 6 months as medication heavy. Some patients respond within 2 weeks, and that prednisone is a game changer. I never promise that. And it really just depends on the presentation. Hope was diffusely affected and extremely itchy as well. So she had allergy on top of it, but she had so many details to her case that were different than a lot of our pemphigus presentations. So for her situation, I definitely said, we are going to be on medication lifelong on some level. And my goal for every patient is to use prednisone to induce remission and then to taper it, whether it's quick or slow. And that patient dictates the taper for sure. The intolerance of steroids in some patients is it's amazing how a dog will go home and never show a side effect of prednisone after months. And the clients have no problems with it. Dogs never pee in the house. Like, we have no problems. And then months and months of therapy, doing great, whatever the dose is. And then you have patients that go home and within 2 days, the dog is eating cabinets and, biting the other dog and, urinating everywhere. And eventually has, muscle wasting. And, it's just amazing the breadth of side effects that can come from prednisone. And every patient responds to prednisone, or steroids, I should say, differently. So our patient absolutely dictates that taper regarding side effects. There are some situations where we use prednisone and then have to go on to maybe methylprednisolone, dexamethasone, triamcinolone to reduce side effect, but we still need the drug. And so if I'm really trying to get remission, induce remission for an autoimmune disease, I really try to get that client on board to hold on as long as possible. And usually in the first 2 weeks, maybe I'll make a dose change if the patient shows improvement. But really that ends up being because my secondary medication is on board, and I'm really optimistic. It doesn't always work out, but I'm hopeful that in the first 4 weeks of using prednisone that the secondary medication will start showing benefit. But there are times when we have a really hard time using a steroid at our higher end dosing, maybe high anti-inflammatory or the lower end of immune suppression. And we have to taper that patient off a steroid faster than we want. And that's where topical steroids end up being hopefully an adjunctive therapy if there's few lesions or not diffuse lesions like HOPE, the facial pemphigus patients, whether we're using topical steroid or tacrolimus even, depending on where they can lick it off, if it's on their nose, nose pad or face. It ends up being so individual to the patient. The template is steroids to induce remission, and then a secondary drug to take over steroids. Once they are in remission, if that's possible with both drugs, I tend to make a dose change on prednisone every 2 weeks. Okay. I don't know. It's just something I try to follow. And I had somebody tell me a long time ago, reduce the dose by 25% every 2 to 4 weeks, And so I don't know. I try. If it's a twice a day prednisone, I maybe start with the evening dose or pick one dose. Pick a dose, cut it in half. Pick a dose, remove the dose. And I try to stay on that dose change. So change the evening dose every time. And then eventually we'll just have a morning dose left over. And then maybe we'll have the ability to change the morning dose. I think owners, we try to connect with a basic approach and make it simple. These aren't simple cases, but and we've stressed compliance. We're going to help you if you can help us, but this will fail, or it'll be extremely hard, or we're going to come out of remission if we don't have that compliance, at least with communication, if not in the office.
So the last thing that I want to talk about before I let you go today was actually a particular combination that you used in this case, because I have heard that this is a no-no, but you actually used oclacitinib, Apoquel, with prednisone and azathioprine, I guess all three in this case. But it's really the oclacitinib and the prednisone that I kind of wanted to focus on. So what factors, contributed to your decision to use that combination in this case?
She was one of my worst pemphigus patients I've ever seen, because the other thing about HOPE, like I mentioned a couple of times, was her allergy. I've had pruritic. I've had the itchy pemphigus patient. She was very different. There are patients that we feel, for example, prednisone just doesn't work anymore, or we exhaust a medication for either allergy or other things, or they come out of remission, and so now that medication was working, but now it appears like it's failing. And because I saw her often, which was great, she was very close to the practice that we saw her in our satellite office in Washington, and the practice that she went to work, with her owner was very close, so we could get her in pretty frequently. I tried to go with my kind of template of I'm going to treat her pemphigus, and I used steroids, and I think HOPE is still on steroids, ongoing, but she needed pruritus care. And I was hoping to induce remission with prednisone and use modified cyclosporin. I was very comfortable with modified cyclosporin at the time for the average pemphigus patient. It doesn't work in every patient. I do feel like if we can get a good price, unfortunately, the drug is more expensive, by brand name for dogs. But when we get a generic, if we can find the price, keep the GI upset under control, then we can most time work hand in hand with modified cyclosporin and do well with our patient. She didn't respond to it the way I wanted her to. And so like through the whole description of her medication list, we ended up changing from prednisone and modified cyclosporin to prednisone, modified cyclosporin, and azathioprine. And so unfortunately I had to kind of transition her off one onto the other. And what was happening is prednisone was shining as our benefit, and the other medications just unfortunately were appearing to fail. I don't know that they had a chance to succeed for as severe as she was. This dog was followed very, very close, and she had so many lesions, and the activity, the severity of the lesions, her foot pads especially. And I didn't want her on prednisone ongoing, but every time I tried to taper her off, she would either flare with her pemphigus, meaning she'd come in and I would think she had a pyoderma lesion. We would do a cytology on a pustule and she had acantholytic cells, no pyoderma. Sometimes she would have pyoderma on other lesions. So she would have a mix of a bacterial pyoderma that they were constantly bathing, which was wonderful. They were wonderful, for her care. Her client or our clients, her owners were very diligent, to keep her skin clean because I didn't want to use an antibiotic in her. And she had an MRSP, so we had limited options. So we're using prednisone, trying to reduce secondary infections. We're using azathioprine now after transitioned off of cyclosporin. Trying to taper the prednisone. She gets severely itchy because she came back into our pollen season, unfortunately. So that's when we did add oclacitinib to a patient that was on 2 immune suppressive drugs. And technically oclacitinib at the dose that she really did require was twice a day is an immune suppressive drug. Her blood work was monitored so frequently. Again, nice thing about working in a vet office. And her vet was on top of, lab work changes. And we did flex, as we needed to. We tried to adjust doses where we could. And she really ended up settling into a combination of drugs that is unconventional. Prednisone at very low dosing. It is a very low dose, but it's still a good dose. It's still a sub-anti, I guess, just below anti-inflammatory dosing. Some allergic patients do need prednisone ongoing, so I'm not surprised about it, but I needed it for the pemphigus. Then the azathioprine held her enough that I could keep the prednisone dose low, but unfortunately her allergic itch was not controlled with that
allergy
prednisone.
really needed it.
And she absolutely needed that Apoquel. Unfortunately, she ended up developing, and this is something I was concerned about, with her young age and the lesions I initially saw, but she does have multicentric lymphoma now. And I don't know, and I cannot say if the medications she was on had anything to do with that. And again, we really don't know what age she was, assuming her age was correct at the time of presentation. She is treated with her regular veterinarian, and we spoke recently, but it wasn't in the past 3 or 4 months. I think it was before the new year. I do know that she had that she was diagnosed with lymphoma, but she was feeling good and her skin was good. I don't want to say that like it's a compromise, like, well, we got this under control and now she just has to deal with lymphoma.
Well, it's a sad update, but at the same time, she came in to be relinquished for euthanasia. And so I think you can take a lot of solace and really know that you gave her a lot of time. She had a wonderful, devoted family, or does have a wonderful, devoted family, just like you said. And so, so I think, taking away the positive from that.
Yeah. And there are patients that I've managed for pemphigus foliaceus, bulldogs especially, they are just tough. That I don't want to use the word fail. It's not fair. I think our clients are referring vets, us, our technicians, we take these cases so personally. They are so hard. They're hard on us because we see a patient, we see every bit of what they're dealing with on the surface. So when we see them at their recheck, we're seeing the side effects of prednisone sometimes on the surface. Calcinosis cutis as a side effect of prednisone, the muscle wasting, the muscle atrophy, the tired patient, the potbelly patient. You can see the effect of that one drug that maybe got them into remission, but now they can't get off of it. And then you maybe see side effects or hear about side effects of the secondary drug. Maybe they have diarrhea all the time. Maybe they can't afford the medication, so they can't use it. Maybe they're having changes on their blood work that, are causing us to have to shift out of one medication to another. These are hard cases. And I've had patients that are euthanized earlier than you'd expect for their age, a 3-year-old dog with pemphigus and not lymphoma. And we can't manage to get it under control. And the side effects of drugs, off balance the quality of life. And as much as Hope looks great in her photos, and I am very sad for her update, I do know, and I appreciate that we did afford some great days, and her owners were wonderful, and her veterinarian did a wonderful job and co-managed. And it's hard, you take these personally, but hopefully you learn from every single case. Yep. I know it's not ideal to put prednisone and oclosetinib together, Apoquel together. And I know it's not ideal to have azathioprine on board either. And I've had patients that way back when they were on prednisone for allergies, and when Apoquel first came out, a patient sitting in ICU with liver failure or something, I'm like, get them off the steroids. Let's try this new drug called Apoquel. And I think it has to be a big discussion points. It's so important. The client's on board. It's so important. Everybody's on board. Quality of life measurement in our patients outweighs, I can say it outweighs, longevity, but we're looking for solid, positive, great days with our pets. We're not looking for, Guinness Book of World Records for a patient living 25 years, or if a patient has some lesions that are managed with topical steroids to avoid prednisone. We have so many patients that are in unique stories, unique situations. We have to flex and change with every patient.
Yep. And everyone is an opportunity to learn, and hopefully through, your article and this podcast, Hope has just, taught so many veterinarians. So that's really exciting too.
I hope so. I mean, I don't encourage the stacking of immune suppressives that we had to do with her, and we took a big risk. But I think as long as you're open with your client, and we are available to communicate about that too. If there are hard cases in practice, we want to hear about them because we are going through these hard cases too. These are hard. This is very hard. I struggled with Hope for a long time. She was a tough. Every time she came in, she was tough, and she got sassy. The better she felt. She was not always very nice, but she was fun to work with for sure. I think she was done with the process. I think after a while, she was a good dog. She's a very good dog.
Yeah, good.
Yeah.
Well, that was all of my questions. You answered everything so thoroughly. It was a wonderful conversation. But before I left you go, no, it was great. Before I let you go, though, I have some questions for you, some quiz questions for you. Actually, it's just a little game. It's just they're would you rather questions. There are no right or wrong answers. All right. So really quickly before we wrap up, would you rather practice without a microscope or without a video otoscope?
Without a video otoscope.
I figured you'd say that. Microscope is really kind of essential for being
I can't smell what it is, really.
Okay. Would you rather star in a reality show about veterinary medicine or perform a live stand-up comedy routine about dermatology?
Oh, gosh. Would I rather? Probably live, because I feel like I would just be so worried about the TV, like the recording part. I get more nervous about that. I feel like I'm off the cuff. I'm better live.
I actually
could be funny.
Live things better as well.
Moments. Yeah.
Would you rather find out the kitten that you were just snuggling is covered in ringworm, or would you rather have a client that wants to show you their rash?
I'd rather see the rash. It sounds weird, but I feel like it gives me some history clues. I've had rashes shown to me recently too. I don't want to snuggle that ringworm. No. I'm good.
Okay. Last question. If you were transformed into an animal, would you rather be a dog or would you rather be a cat?
I thought I was going to pick my animal. I'll go with a dog. Do I have to pick the breed?
No, you don't have to pick the breed unless you want to.
No, yeah, I'll just say dog. I can't think of a breed. I feel like a Cavalier, but without the heart disease and all that stuff. Yeah, I love a good Cavalier. They are really sweet to snuggle. I would snuggle a Cavalier
precious.
with ringworm.
You would. And on that note, thanks so much for joining us.
I appreciate it. Thank you.
Thank you for listening to today's episode. If you enjoyed our episode, you can find us wherever you listen to your favorite podcasts, including a video version now available on YouTube. While you're there, make sure you subscribe, rate, and review us. You can also listen to or watch our podcast episodes on our website at cliniciansbrief.com/podcasts, or drop us a line at podcasts@briefmedia.com. Clinicians Brief the Podcast is a Brief Media production, produced by Alexis, Ussery, and hosted by Dr. Alyssa Watson.